we got another subjects which were not at all touched. So we thought that we should give some time so that even they can come to certain extent, they can come back and then we can go for that. One important thing, yesterday I sent the message, you just go for this, that is therapeutic practical has been assigned to me. Make the groups. I don't know whether you have studied with me earlier or not. No, yes, you have not studied, but last year I think I introduced you initially, I suppose. What I can recall is what you have to do here is, what I am expecting in these therapeutic practicals is, you know what therapeutic practicals are. I will not explain you in more. You know what is SOAP analysis. Now whatsoever cases are there, you find the cases and you make SOAP of each case. And what is my idea, unfortunately students are not follow it in the way I want to do it, or I expect it. My expectations are what is you got a case from any standard thing, and when you are getting that case, when you are going through that case, what you do is you convert that case into SOAP format. What is the subjective data, what is the objective data, what is the assessment, what is the plan. Now once you make it into SOAP format, what I am expecting is you have got 4 students in each group, so each will take, somebody will explain subjective, somebody will explain objective, somebody will explain assessment, somebody will explain plan. But it doesn't mean that that particular person has made it. Actually you are reaching to that particular final data after discussing with each other. All the 4 are discussing it and they are finalizing it. Now how you are finalizing that data, or how you are finalizing that particular case related thing. You have to assume that the case you are working is in front of you. You have to think that that case is there. But you have got the advantage is you have to suggest treatment after 7 days. But it has to be accurate, otherwise you think that you may be punished for that, you may be given any punishment. You think in that way. And if you think in this way, then definitely your clinical knowledge will improve, otherwise it won't be. Because if you are doing it as a ritual, then yes, so many courses will come and so many things will be there and you will be remain there only. Now suppose we are finalizing it every Tuesday, just like this. Okay, this discussion. Now what I am expecting is, or what is suggested is, you are going for that case and you are putting it on group. Why you are putting it on group? 2 reasons. One is everybody should know about what case you are going to take, because whether it is relevant with the topic or not, so you are reading with all the cases you are the people or the groups are putting over there is one thing. Second thing is you are aware about what others are taking about. If it is very similar to that, or it is almost same case, then you are avoiding it. Suppose the first group has put the case, then you read it. Second group has put the case, you read it. So before adding third case, your case, you just check whether it is not exactly copy or it is not the same case. That will avoid the problem. Now what you are doing is, once you have put the case, anybody from you is putting the case over here from the group. You are 4 members in the group. Now on this, everybody, suppose you are taking it from a book. Example, what book it is? Maybe Koda Kimball, or maybe this Deep Hero, or anywhere you are taking case, and it is a ready-made case where answers are provided. There is no harm in that. But my suggestion, my advice is what? You are not going for checking the answers. What you are doing is, you are referring the case and you are referring the guidelines. This is the case and what this data suggests. This data suggests mild case, moderate case, severe case, any particular complication in the case, and what the guidelines suggest into that. So on the basis of subjective and objective data, what points are leading to any kind of assessment you can have, and from that what judgment you can draw. Okay. Then immediately, if your guidance are asking for more diagnostic test, you should put it in points to physician that go for this kind of diagnostic test. These are what the issues which are there in the point of physicians. Whenever you are writing anything in the point to physician, your tone should not be authoritative or ordering tone. Your tone should be sort of suggestive tone, advising tone. In last few years I have found, and students have not changed despite so many warnings. Do this, add this, do this test, this drug should not be given, this should be given, this dose should be given, this should not be given. This is not the way. In the hierarchy, the doctor is higher to you. Even if you are going to hospital, he will not be your subordinate. So your tone should not be like ordering it. Your tone should be on the basis of so and so guideline. It is recommended, it is advised that this diagnostic test can please be conducted, it may please be conducted. So that gives good sense, it gives good what we can say, acceptance to you. Otherwise it becomes a confrontation mode, that you are ordering something. Okay. Now you may be wrong, but this, if the ordering tone is there, then it makes everything wrong. So go for this. You make all this and you give the references for that on that basis of this guideline, I will recommend, I will suggest to replace this drug with this drug, or this drug with this dose with this dose. I will recommend to add this drug, I will recommend it to withdraw this drug, I will recommend to, or I will suggest, or I will advise, I feel, I think this should be done. So these are the words which makes a better one. So this way you are adding, you are putting it, and these are based on the knowledge and not on the basis of something. मैंने physician को advice नहीं दिया तो sir मेरे mark काटेंगे. It should not be the way. You should be very thorough. You can even very clearly claim that there is no advice from my side because everything is correctly done. Once you do it, then points to patients, check what are the. Many times students are doing a big mistake. Do healthy diet, take healthy diet. So rather you should see that what is a healthy diet means. You should able to recommend, or you should say that please take appointment with the dietitian who should suggest you the appropriate diet for this particular condition, appropriate condition. Or then if do not smoke, you can say definitely, but if it is there, you can say that I am recommending you to the smoking cessation program, and you go for that, so that you can quit this. If it is alcohol, then you can suggest in that way that if you find it difficult, there are ways how you can quit the alcohol, and you can take their help. But if you continue taking alcohol with this, then if there are some interaction, you have to put it there. There are certain drugs, example, if you I think you have got more chemotherapy, I suppose, isn't it? So if it is chemotherapy related drug, then you can have this problem, that is if it is rifampicin, then it will cause change in the urine color. You can say like that this will cause this. Those which are hepatotoxic drugs, or example INH, rifampicin, etc., then you can say that you can put to point to physician also that the liver function test may be done with after 3 months, 4 months, usually whatsoever period is important, like that. And this will come only when you have studied it in that way, in such a way that yes, this case means he is my relative, or he is a very influential person, and if something goes wrong with him, I will be in difficulty. Then only you can think about that case in very clear way, and you can give that justice to the case. Otherwise it is very ritual one, and definitely one point of time you will feel that it is not of any use of doing this kind of cases. So my suggestion will be this: you follow this. how you are going to do this? As I told you, suppose next Tuesday you are going to put the case, present the case. Then what you are going to do is you are putting the cases today. Every group individual will be reading it thoroughly, once, twice, thrice. Read it, make note out of it. What is your idea about the subjective data? What subjective data you have understood? What objective data you have understood? You are not missing a single word out of it, because every word carries important impact on the case and the treatment. So you go for it. You read each and every line and sentence carefully. Try to correlate it, the meaning and the outcome or impact of it on the case. Accordingly, try to judge the severity and try to match it with the model. Which kind of model means guidelines? What are the model guidelines or the therapeutic algorithms where it fits, and check it whether it is there. In that case, if something is not there as per the guideline, then try to understand what can be the reason. If it is deviating from the guideline, whether that case has got something typical case. If it is not, then you can mention that as per guideline this should have been there. And now in group there are 4 persons. Suppose group A, A1, A2, A3, A4, or B, B1, B2, B3, B4. Now A is doing this, B is doing this, A1 is doing this, A2 is doing this, A3 is doing this, A4 is doing this. In group A, all 4 are doing individually and taking time of 3 days. Now they should compare ki, yes, A1, what is your subjective? A2, what is subjective? A3, what is subjective? A4, what is subjective? A1, what is your objective? A2, what is your objective? A3, what is your objective? A4, what is your objective? A1, what is your assessment? A2, what is your assessment? A3, what is your assessment? A4, what is your assessment? Again, plan, same thing. A1, what is your plan? A2, what is your plan? A3, what is your plan? This is after 3 days you are doing. And check the differences. Why there are differences? Is the thing that what I have not understood, other has understood? Is this the thing I have missed something about the case? Is this the case whether I have missed any kind of important thing and or important guideline I have not read, or whether there is a difference between the guideline I have used and that fellow has used? Okay, this will give you idea where you can correct it, how you can correct it, and try then where this is giving you, see, these 2 or 3 cases may not develop your knowledge, but the mechanism how you think about the cases or how you act about the cases, that will develop you, because this will be accessible, that this is the case and this is the data. It is accessible. If you want it is accessible. What are the guidelines? Okay, so you have to understand whether you can understand it properly or not, where there is a mistake, and then how you can improve it. And for this thing, I am suggesting, my recommendations are there, at least 5 days, 4 days for that. If suppose we have to go fast and we have to conduct twice a week, then in that conditions you have to see that how fast you can go. Initially you keep once in a week, you try to make that particular mechanism, that how you are learning about it and how you are using about it. This much is clear. Is there any difficulty?
सर
हाँ
हॅलो
हाँ ओंकार.
आता एका ग्रुप मध्ये 4 स्टुडंट असतील ना,
हो
त्यांचा एक टॉपिक असेल, बरोबर असंच ना?
हो
हा, तर तुम्ही आता म्हणले ना की पहिला पर्सन, दुसरा आणि तिसरा आणि चौथा सब्जेक्टिव्ह, ऑब्जेक्टिव्ह, असेसमेंट आणि प्लॅनिंग,
हो
प्रत्येकाचं इंडिव्हिज्युअली अॅनालाइज करेल आणि नंतर त्या चौघांनी डिस्कशन करायचं 3 दिवस. मग चौथ्या दिवशी आपल्याला प्रेझेंट करायचं असेल.
नाही, तसं नाही म्हटलं मी. ओंकार, काय करायचं आहे आपल्याला, आता तुझ्या ग्रुपला तुम्ही 4 लोक आहेत, बरोबर? ती केस तुम्ही टाकली ग्रुपला, सगळ्यांनी बघितली. आता तुम्ही काय करणार, तुम्ही चौघांनी ती केस बघितल्यानंतर ओंकार आणि बाकीचे 3 प्रत्येकाने आपली इंडिव्हिज्युअली ती केस ही करायची, सॉल्व करायचा प्रयत्न करायचा आपल्या आपल्या पद्धतीने. सब्जेक्टिव्ह ऑब्जेक्टिव्ह असेसमेंट प्लॅन लिहायचा तू. मग तू काय करायचं, तुझ्या ग्रुपच्या मेंबरसोबत चेक करायचं की तुमची एक इंटरनल छोटी मीटिंग घ्यायची, गुगल मीटला म्हणा किंवा कशाला म्हणा, की तू काय लिहिलेलं आहे सब्जेक्टिव्ह, आणि समोर केस ठेवायची. तर सब्जेक्टिव्ह तू काय लिहिलं आहे, मी काय लिहिलं आहे, ऑब्जेक्टिव्ह तू काय लिहिलं आहे, मी काय लिहिलं आहे, म्हणजे 1 नंबर 2 3 4ने काय काय लिहिलेलं आहे. याच्याने एक अंदाज येतो की आपल्यातलं कोण काय मिस केली. समजा एखादा इम्पॉर्टंट पॉईंट होता सब्जेक्टिव्हमधला, असेसमेंटमधला, ऑब्जेक्टिव्हमधला, प्लॅनमधला, तो लक्षात येतो पहिली गोष्ट. मग आपल्याला लक्षात येतं की आपण ते मिस करायला नको होतो, का आपलं रिलेशन्स त्याच्याशी सोबत लागते, बरोबर. मग तुम्ही प्लॅन केल्यानंतर कोणाची तरी त्याची चूक समजत येईल त्याच्यात, किंवा चूक कोणाचीच नसेल पण तुम्ही रेफरन्सेस वेगळे वेगळे घेतलेले आहेत त्याच्यामुळे तुमचा डिफरन्सेस येतो आहे, तो आपल्याला लक्षात येईल की व्हॉट इज द रिझन बिहाइंड डिफरन्स, whether it is because of my mistake, whether it is because of my lack of knowledge, or whether because of the differences in the guidelines. तुम्ही दोघांनी रिसेंट गाईडलाईन वापरल्या, एकाने US वापरली, एकाने कॅनेडियन वापरली, एकाने इंडियन वापरली, एकाने नाईस गाईडलाईन वापरली. देट कॅन बी द रिझन. मग आपण तो एक रिझन लक्षात येईल आपल्याला. म्हणजे इनडायरेक्टली तुमचा एक इम्पॅक्ट, तुमचा स्टडी काय होतो की त्या केसमध्ये वेगळ्या वेगळ्या गाईडलाईनमध्ये काय डिफरन्स आहे इमिजिएटली तुमच्या लक्षात येतो.
आणि सर
ऐक ना, पुढचं ऐक माझं. पुढचं झाल्यानंतर पुढचं हे सगळं झाल्यानंतर तुम्ही मग फायनल बनवता त्याची, की सगळ्यांना ॲक्सेप्टेबल फॉर्म काय आहे त्याचा, की तुझा अभ्यास चांगला आहे, तू कन्व्हिन्स करू शकला, किंवा दुसऱ्याने कन्व्हिन्स केलं की नाही ओंकार तुझं चुकलं आहे, माझं बरोबर आहे. तर त्याचा एक तुम्हाला 1 दिवसाचा टाईम घ्यायचा तुम्ही 3 दिवसानंतर किंवा याच्यानंतर, की तू पण व्यवस्थित अभ्यास कर, माझ्या मते हे व्यवस्थित आहे. आणि हे 4-5व्या दिवशी तुमचं हे केलेलं आहे. 6व्या दिवशी बाकीच्यांच्या केसेस एकदा बघून घ्यायच्या तुम्ही कन्फर्म झाल्यानंतर, की बाकीच्यांच्या काय केसेस आहेत, त्याच्यामध्ये काय प्रश्न येऊ शकतात, जे तुम्हाला प्रश्न विचारता येतील जेव्हा बाकीचं प्रेझेंट करतोय तेव्हा. आणि 7व्या दिवशी जेव्हा तुम्ही केस प्रेझेंट करताय, यू आर व्हेरी वेल इक्विप्ड अँड व्हेरी कॉन्फिडंट ॲक्च्युली. तुम्हाला कोणी प्रश्न विचारले तर तुमच्याकडे तुम्ही कुठल्या गाईडलाईनवर अभ्यास केलेला आहे, कुठल्या गाईडलाईननंतर सजेस्ट करताय ते तुमचं येईल. दिस इज व्हॉट माय सजेशन. आता बोल, तुला काय अडचण असेल तर.
नाही, आता क्लिअर झालं सर, थँक्यू.
अजून कोणाला डिफिकल्टी काही?
Hello, sir.
हां.
Firstly, you mean firstly we have to share only case on group. After
Yes.
that, each individual of the group should have to prepare so format.
Yes.
And then after discussion, finalize it and have to present.
Yes. But basically.
And sir, our
हाँ बोल अक्षय, आकाश बोल.
yes, sir. And also sir, our oncology pharmacology portion is remaining. So I thought that we should keep this case presentation lastly.
Yes, 100%. See, I am parallelly starting this now. Hello. See,
Okay, yes, sir. Yes.
soon, Akash, I am not sure what has been taught in Thera classes, because Thera classes were not with me. I am teaching pharmacology. Akash.
Yes, sir. Yes.
है ना? So I am not
Yes.
sure what has been taught in Thera classes. I am not sure. If not, and what you have planned in Thera classes, I am not sure about it, which I do not know. But whatsoever things are remaining pharmacology, which I am going to cover, which I have planned. Already I am going with the fungi now. We'll try to complete some of the fungi, and remaining we shall complete in the due course of time. So similarly, we'll go for pharmacology, but Thera, you just be in touch with sir. Only practical aspect I'll be covering. If the theory classes are not there, then you have to get it. Huh.
Okay.
Okay.
Sir, actually, in therapeutics, our I mean not properly teaching here. That's all.
Maybe this difficulties
And
we can.
also
Yes.
and also our concept not too much more clear. That's why I'm saying.
No, but see one thing now, Akash, see these are the problem actually. This year we are too much, we all are actually, let me tell you, we all are in great difficulty, and fortunately everybody has ready to take. Actually this was not, everybody is almost 3 or 4 times more loaded than normally what it should have been. and even the persons have to take the classes which they never thought of teaching, because they are teaching one or other course, and now all of a sudden this has happened that because of some difficulties, online classes regulation and all, CHB teachers are not there this year, and therefore everybody who never thought about this type, this is happening with everybody. Some student may not be even happy with my teaching because this is totally new or difficult or different subject for me. This can happen, but then we have to find out way in that. There's no other way we can do anything about it. So basically we are studying it in pharmacology. What is therapeutic is application of the same knowledge into therapeutics. We have discussed in the beginning. What we have to do is, that what are various drugs are available, and now that various guidelines are available. Guidelines are there are too many guidelines. You search them, you read Deep Hero also, but Deep Hero is comparatively older, because whatsoever copies and versions we are having, soft copies, it's quite old version. After that, one new version is also there, but soft copy of it is not available. I don't know if anybody is available having it, they can share it. But the latest version which came around 3 years back, we don't have copy of that latest version of. So this is another thing, and basically this is a science which is continuously updated. So what is solution for that? Go for the Google search and go for the current guidelines. You can in Google you can make the restrictions, that is maximum 2 years old, 3 years old. So up to 3 years old you can have the guidelines. Check about guidelines and get these guidelines, and otherwise the most important resource you are having is the NICE guidelines. You can go for that. Have you ever seen about NICE guideline, NICE pathways?
Yes, sir. Yes.
Okay, so go for NICE pathways. Pathways are short, you can immediately go for that, and you click on the things and you will get the NICE guidelines on each on that pathway. So once you go for that, then you are equipped with it. Basically you have got the knowledge of pathology, you have got the knowledge of pharmacology. With that pathology knowledge, you know about the diagnostic criteria and the severity condition. This is one important aspect which is there in the therapeutics. You have to finalize the severity condition, whether it is mild, moderate, severe, like that. And accordingly in that condition, what is drug is to be given. The pharmacology of drug, and guidelines will tell you that is in that particular condition. Once you judge it, once you assess it, whether it is mild, moderate, severe, then you will find the what is the best way, what is the best system for that, and in that condition that will help you the most. So don't worry whatsoever has been taught or not, in what way it has been taught, don't worry about it. I hope I have made it clear.
Yes, sir. Yes, clear.
Yes, sir.
Now particularly I am happy with your batch, other, because you are trying to study. There can be few exceptions, no problem, but anyway, if you are going to try, one thing everybody has to keep in mind, see, this type of conditions are there, these are unique conditions, there are so many difficulties. Teachers are there to help you. Even teachers can have their own limitations, but yes, still they are ready to help you. Now in that conditions, when it is not there, you have to become somewhere like Eklavya's. That is, yes, if teachers, because of the constraints, difficulties, they cannot give you, you should try to prepare and take help, and definitely I am always with you, don't worry about it. Okay, so you try, you can put your difficulties. By chance if I am not available, or I have some difficulties, some time constraint, you can definitely get back to me. You can even pursue it. I will not angry upon it, don't worry about it. Okay, because basically you are there for learning. Those who are learning, I will be always appreciating. So don't worry about it, we will do it in this way. I hope this is clear.
Yes, sir.
Yes, sir.
Okay, so yes, anybody has to speak, they can speak. So we can go in this way. Parallelly, we'll complete the things which are left. My suggestion in that case is I need that you are reading it simultaneously, uh, because as I told you, so many things are there. As I told you, we had last week. You might have seen the this one YouTube links. That is, last week we were having the teachers training program, which was hosted by our college. It has been put on the YouTube, and so many teachers, more than around 100, around 150 teachers from different part of India were attending it. So we all were busy and occupied into it, either listening, delivering, or managing, or doing all three activities. So this was the case. So this we do have our own difficulties, and in that case we are always there to help you. But maybe sometime we will not able to do it immediately. It will take some time, and I am also expecting, or our teachers are also expecting, that you should have some contribution, or you are also trying something from your side. If we do this, once this time goes, maybe some better days we'll have, but these are the difficulty at present we are having. I hope I have made it clear.
Yes, sir.
Okay. So basically this is a microbiology aspect. Fungi, how you classify them, and you can find that there are variety of ways by which you can classify them. And nowadays everybody is very much concerned about the fungi, because they are playing havoc along with this COVID, and making a situation very worse. Basically fungi we can classify in two major classes: yeast and molds. In yeast there are candidas, cryptococcus, then pneumocystis species. There are certain who are having both yeast like and mold like structures. We call them as a dimorphic, and there are again many species are there, like histoplasmosis, blastomycosis, coccidiomyces, then paracoccidiomyces, then this pyrocytosis, then chromoblastomycosis. These are various mycosis. Most of time that indicates fungus. In molds there are species like Aspergillus species. Then other is dermatophytes like Trichophyton, Microsporum, Epidermatophyton. As the name indicates, they are basically are responsible for skin infections, and there are so many fungal skin infection we can see. Then another one is a mucormycosis, which is nowadays making a big news, big things, that is. And this is the Rhizopus, Rhizomycor, Mycor, Absidia. These are from the Zygomycetes family. So these are various fungi which are supposed, or which can be pathogenic. If you have read the news, and mostly fungi are that way, they are available, they are always present, but rarely they cause infection. Very few times they can cause infection, because host immune mechanism is potent, powerful enough, and that can take care of it nicely. But once it is not there, then there are infections, and then these has to be treated with the treatment. We should have the antifungal agents to treat it. There are another fungi also which are not coming in these two classes, yeast and molds or like that, and we put them as a miscellaneous, like Pseudoalerceria, then Pseudosporium, Penicillium, Fusarium, and such species are there. These are various fungi we have, and from this fungi this one. So these are various fungi. Okay. So we should have antifungal drugs. Ideally, what it should have? It should have wide spectrum of activity. We have seen the spectrums. We have seen two classes. Okay. And a variety of that. It should be wide spectrum. It should have good pharmacokinetic one, so that it can be, example, it can be orally absorbed, so that you do not need to give injections like that. It should be well absorbed. It should have adequate in vivo efficacy. It should have low rate of toxicity, low tox. Normally it doesn't, no ideal drug is available, nowhere it can be there. Then next is what are the drugs what are the risk factors for that. Again, you might have read so many things about mucormycosis, so many things are there, what are the reason, why it is causing, basically, and there are so many things are there. Examples of this you can see, antibiotics can cause, if you remember the antimicrobial agents which we have seen, and if you remember super infections, that the normally bacterial flora which is there, which is affected, so these antibiotics can cause the fungal infections. Then catheters, then hyper alimentation, multiple abdominal surgeries, prosthetic material means any material which is not body tissue, which is put in, example, heart walls, from synthetic heart walls, synthetic plate, synthetic something, or synthetic here means steel plate, or synthetic silicone, or ceramic, or any other such material which is replacing the human. Then in case of severe burns, where the body immune mechanism or barrier function is lost, neoplastic diseases, because we are taking chemotherapy and we are taking immunosuppressants in neoplastic, or they are causing immunosuppressants. Diabetes mellitus, because increase in blood sugar. Again, those who are studying, I am happy with your class that they are putting something over that. Mucormycosis, you may find that the most important reason is increase in the blood sugar level, particularly because of any reason, whether they are diabetic or non-diabetic, but because of the glucocorticoid therapy they have got the increase in the blood sugar. So in that cases it is there. Or extremes of the age, that is, as the age increases, the immune power decreases, and as I told you, otherwise which is not pathogenic, it can become pathogenic. Then because of the granulocytopenia, decrease in the neutrophil numbers or functions, T cell dysfunctions, because T cell plays important role. If you remember our initial topic of immunosuppressions and immunomodulatory agents, you will understand it. Then corticosteroids, again they causes the problem, we know about it, granulostomatous diseases, AIDS, burn patients. So these are various reasons why there can be there. I'll not go for these mortalities because it's part of therapeutics, but you can see that these are various reasons why there can be fatalities, and how the cases, or why the cases will increases into it. Now, what are the mechanism of action, and we can classify these on the basis of things, whether we can take it in some form so that it will reach to the circulation, or it will go into blood, and from blood it will reach to the site of fungal infection place. We call them as a systemic infection, systemic agents, or otherwise there can be agents which are working which cannot be absorbed nicely, and therefore they have to be applied to the site of action, as we have seen that particularly dermatophytoclast, which is doing, or which is causing the various skin fungal infections. So we have classification either systemic or local, and both, either systemic as well as local. So which are the systemic agents? The membrane, the agents which are causing disruption of membrane, that is amphotericin B. The agents which are causing nucleic acid inhibitor like flucytosine. The ergosterol is a very important, we shall see about it, very important. Just like we have got cholesterol and lipids in our cell membrane, and similarly ergosterol is there, which is very important, and it is there. So that synthesis inhibitors like azoles, and then glucan synthesis inhibitors like echinocandins. These are various drugs which are used as a systemic one. Now the most popular nowadays, it has become a hero, I think, that is amphotericin B. I think this is very apt time we are going for antifungal, which we have stopped, because Otherwise you would not have got understanding how serious it is, because so many cases, whether on television or media and WhatsApps and everywhere. So what it is a polyene. It is used since 1960. It is insoluble in water, and it is solubilized by sodium deoxycholate. If you remember, if you know physiology, then oxycholic acids, these are the bile acids, and these are converted into bile salts, and they are having surface active agent property which can solubilize. This is the most broad spectrum antifungal agent. It is a gold standard. Now this word is used many places in therapeutics, pharmacology, everywhere. That means this is the best treatment, or there is no good alternative to it, or there is nothing best than that. So pharmacokinetic, it is extensively tissue bound. Highest concentration is found in the liver, spleen, bone marrow, and less in the kidneys and the lungs. Half-life in the tissue is around 15 days, and in plasma it is just around 5 days. What is the mechanism of action? See, this is the structure of the fungal cell wall, and here you will find that just like human cell, you will find that it is a bilayer structure, where you can find that lipid and polar molecules are there. You can see these heads and tails of that. Okay, this lipid bilayer molecule is there, and there are the sterols are present. This ergosterol is present. It will bind to ergosterol and alter the cell membrane permeability, because once it binds to that, it will cause the weakening of this phospholipid molecule, because phospholipid molecule is having ergosterol, just like we have cholesterol as a lipid in phospholipid. So this will be there, and that will cause change in the permeability. If the permeability changes, so anything can go inside easily, and whole homeostatic mechanism of that fungi will be ruptured. It can also bind to cholesterol, and therefore it can cause adverse effect in human beings. Although the selectivity or specificity towards ergosterol is comparatively much higher, several folds higher than that of cholesterol, and therefore it is there. Clinical activities, it is active against candida, it is acting as cryptococcus, blastomycosis, it is histoplasmosis, aspergillus, zygomyces, and mucorspaces. We have seen all this. As I told you, this is the most or this is the biggest hero nowadays, and it has little or no activity against aspergillus, fusarium, then pseudoalisteria species, then pseudosporium, and trichosporum bigili. So against this has no activity. This is very important, that maybe because of the species difference and the structural difference, that these drugs may not be active against this. If somebody has seen on WhatsApp, it is moving. In case of mucormycosis, only 2 drugs are highly effective. One is amphotericin B, and other is anybody. What is the other drug which is effective?
Posaconazole, sir.
Yes, very good. It is a posaconazole. So only these 2 are very effective. Very good. I appreciate. Therefore, I like you people class, that is, you are trying to read something, trying to do some good things. Okay. Then next is the problem with amphotericin, and why it becomes amphoterrible instead of amphotericin, because it can cause nephrotoxicity, particularly more because of the cumulative doses. Unfortunately, in this mucormycosis, you know how many injections people have to be given? Anybody?
Sir, I'm not sure, but I guess I have heard that 80 to 85 courses.
So almost 100 injections. So you can imagine the adverse effects, because it causes nephrotoxicity with cumulative doses, concomitant administration of nephrotoxic drugs, then hypotension, those which are having hypotension, because it will not be excreted rapidly because of the decrease in the GFR, glomerular filtration rate will be reduced. Extravascular volume depletion, if it is there, pre-existing renal diseases, and BMT I have to check. BMT patients, in that it increases toxicity. So for that, hydration and sodium loading has to be maintained, or it has to be increased so that it can reduce the problem, because it will be washed out easily. Infusion related reactions are there. They are very common, most severe in the first few doses, just like hypersensitivity reactions. It can cause electrolyte abnormalities, decrease in the potassium, magnesium, phosphate, and it can cause thrombophlebitis. Thrombophlebitis is a very common, particularly many injection, if you remember injections of insulin, etc. That is where at the site of injection at that places there will be damage, and particularly this blood vessel will be having inflammation of that. So therefore it should not be administered in the peripheral lines, otherwise they are smaller one and it will cause problem. It can cause anemia also. So this is what about amphotericin B. Amphotericin B has got a problem, and therefore it is again, you might have noticed nowadays that people, if those who are asking for amphotericin B, nowadays so many calls are there, and they are asking not for a simple amphotericin B, but they want for a special formulations which are made about amphotericin, which is very, that is liposomal amphotericin B, ambisome and such kind of liposomal preparations, because liposomes, they increase the viability, and they improve the activity of the drug. So these are typical formulation which are in lipid, that is amphotericin B colloidal dispersion. It is called as ABCD, that is amphotericin B colloidal dispersion, amphotericin B lipid complex, or amphotericin B liposomal injections. These are very popular, and these are having better viability. It causes less nephrotoxicity comparatively, because they are easily, yes, they have got good tissue penetration, so their blood concentration decreases, and since tissue penetration increases, therefore their efficacy increases in comparatively lesser doses, and therefore these are having lesser adverse reactions. Only thing is, this liposomal formulation are more costly comparatively. Efficacy wise there is no problem, but only thing is delivery will be higher, and therefore toxicity can be more. Otherwise amphotericin B is the same, dose is same, only its delivery to the tissue increases, and therefore its concentration in blood decreases, and therefore the toxicity at other places that decreases. This is the advantages. So it allows delivery of higher doses, and higher doses required for equivalent antifungal efficacy. Tolerance differences are there, so upper dose that can be administered, if there is a tolerance is there, then we have to go for higher doses, but again we have to check how much dose we can go for. These are pharmacokinetic comparison, how they are made. So particles, if it is deoxycholate, it is a micelle formation. It is a colloid dispersion, they are a lipid disc. If it is lipid complex, then it is a ribbon form, and if liposomes, they are very small unilaminar are there. Yes, true, Sanika, correct. And therefore there is a shortage, and nobody was knowing that India will need this many, and therefore we don't have any manufacturing capacities of this size. So see, this is a comparison, what will be the particle size, and on that basis we can say that what will be the infusion related toxicity because of the particle size, and what will be the chances of nephrotoxicity. You can find that the liposomal has got minimal nephrotoxic, while the normal deoxycholate has got maximum renal toxicity, very high nephrotoxicity. Then serum concentrations are more, they are increased, and the tissue concentration at various places like lungs, kidney. So the liver concentration or liver increases, while what we can say, lungs, kidney, there are no big changes with ambisome. Dosages, you can find that is deoxycholate is given in the low doses, while these all other are given in the dose range from 3 to 5 milligram. Again, because of the toxicity this deoxycholate is having on kidney, we have to reduce the dose, and therefore it may impact on the efficacy. I will not go for clinical cases. The other is candidiasis. The drug of choice in that cases are amphotericin B, fluconazole, itraconazole, voriconazole, and caspofungin. On the basis how we are choosing it on the basis of spectrum, that is what is the spectrum of activity, which is the likely pathogen of this, and there are various documented pathogens of this particular class of candidiasis. Very popular fungal infections, particularly it can occur in females, that is vaginal candidiasis. It can be systemic candidiasis in many, and accordingly what kind of candida, there are many candida species are there, candida albigans and other candidas are there. Candida is a white, albigans is a white, so people can call it as a white fungus. Site of infection, what it is, concomitant diseases, what are the various concomitant diseases simultaneously there, what is the condition of hepatic or renal function, what are the toxicities the drug are having, and on that basis we are choosing. These are the criteria which we should think about, and I think this should help you in the selection of the therapeutics, or when we are selecting it for the therapeutics, what kind of drug interaction it is having, what are the viability if it is given by intravenous route and per oral route, that is orally when it is given, what is the cost of that particular formulation. So accordingly we have got various agents available for that. The oldest, as I told you, that is the amphotericin B, which come around 1958 or so. Then come is a flucytosine, which has got antiviral type activity also, but it has got more adverse reactions. Then came ketoconazole, which is the first in the azole category chemical classification. Then is a fluconazole. Then there are so many we have got, that is itraconazole, caspofungin, voriconazole, posaconazole, and so many conazoles we have got it later. So these are various drugs, azole antifungus, like I think azole and onwards we shall study in the next class. So from azole onwards we shall see the next. Okay, so these are the various antifungal agents. We'll complete antifungal by next, and then we'll go for the other topic. You make the list of topic which you want. So we'll complete pharmacology first, and parallelly go for your therapeutic classes. You can put your difficulties in the meanwhile, and I'll suggest experimental pharmacology. You please go through all the experiments in the meanwhile. Anytime whatsoever we have planned, as I told you, I have given many times, just like politician, I have put you in this one, that next week I'll take exam, but somehow I'm not able to manage, but most probably now I'll able to manage, because I have finished 4th year classes, which were all of a sudden assigned to me, therapeutic classes. Initially we were not supposed to take practicals, but then it came that we thought that practical we can take when it comes regularly, but again practical classes came, and then everything, all the schedules and timetable, we could not, at least I could not manage it, and because of all the activities. But anyway, we'll see it, we'll plan it. You try to make a schedule. You can make schedule in this way, that what will be the next week and what will be the next to next week. So whenever we conduct the second sessional first, then on that topic we'll complete, then we'll go for the third sessional. So this we shall be managing in this way. You divide the experimental pharmacology also in this way, and make it that you are making particularly the list in this way, and all practicals, please go through their videos, YouTube videos, and make your own notebook of these experiments, where your observation table problem you find already nice book has been shared with you, that is this what it is, M.N. Ghosh, which is very good book. So you can see the things over there. and there are many videos are having, they are suggesting how to record it. So please go through it, and then just if you have any difficulty can go for this. Those who are interested can see the YouTube videos of the recent faculty training program which we have conducted. At least you will get some idea about various animal experiments, how they are there, what are the regulatory conditions, what we have seen in case of CPCA, CA, etc. And that will help you to understand it in better way. Try for that, and if you have any difficulty can just let me know. So take care and be safe. We'll meet again. Just provide me what is the best time. Tomorrow also if possible we can go for it. Okay. हेलो, बस निकल रहे एक 2 मिनट में, नीचे से उतर रहे नहीं नहीं, हमारा ध्यान है, साथ है ना, ओके।